Thank you. Hello, so I'm Karen Eastman, I'm a GP, and I'm also the lead for Unwarranted Clinical Variation Programme at Sussex and East Surrey STP. I'd like to introduce Paul Miller.
My name's Paul Miller. I'm the lead trainer and facilitator for Best Possible Value.
So thanks for welcoming us to take you through our journey, and we still are on a journey in terms of our Unwarranted Clinical Variation system-wide programme. So it started by our STP executive wanting to understand where there was unwarranted clinical variation in our patch. We've got quite a complicated geography in terms of 5 acute hospital trusts, 2 community trusts, 4 local authorities, and currently 8 CCGs, which are on a journey to merging into 3. Our clinical cabinet, made up of medical directors and the clinical chairs of the CCGs, were very keen to make this absolutely focused on improving quality across the whole patient pathway to deliver improvements in value. So we had a great paper produced by our clinical senate describing value as achieving the best outcomes for the individual and the population within given resources. Not only do we need to be looking at unwarranted clinical variation, but we also need to identify where we are doing things with little or no value to patients and how we can actually stop that. We need to identify where we've got, where we need to improve our patient outcomes that we're focusing on, making them meaningful. And we really need to focus on the quality of shared decision making within our consultations with our patients. So not only describing the pros and cons of options in terms of their management, but also framing that with the patient in terms of what their health preferences and health beliefs are. So our starting point was the data. So looking at our right care data and our getting it right first time data and triangulating that with our own evidence-based sort of interventions programme of work called Clinically Effective Commissioning. So from the right care point of view, this is some of the data that we've looked at in terms of spend opportunity. So what's our spend difference between ourselves within our 8 CCGs and our demographic peers? And it really lent ourselves to start looking at 3 particular areas: MSK, falls prevention, and cardiovascular. And I'm going to talk about the best possible value approach that we've applied to MSK today. So we've looked at our governance structure behind this programme of work, and we really wanted to make it different in terms of our approach because this is a system-wide approach. So we've started with senior sign-off of this as a programme and those 3 priorities with the chief executives sat on our STP executive. We've got Bob Alexander as our executive sponsor for the programme. And we've really done a great deal of socialising of this programme of work, discussion, listening, reflection with other colleagues within the system. So our finance directors, PMO, senior clinical stakeholders. And we've developed oversight groups for each of these areas. And this for us is really the critical part of it. We've asked our chief executives to nominate senior clinical leads, so doctor, allied health professional, nurse within their organisation to represent their organisation but also bring their clinical experience into the room, alongside also the directorate manager, commissioners, primary care, right care and getting it right first timer in the room, alongside the sort of enablers in terms of the STP digital programme, workforce and quality. And we're working in those oversight groups to hold a collaborative cross-organisational discussion focused on co-creating those evidence-based pathways for our population. That work is then feeding into the project boards, where you've got the project plans and implementation plans, and they will support mobilisation as we move in that direction. So bringing it through onto MSK again, the right care data is telling us we've got £12 million worth of spend opportunity. So we need to understand what that is. So, you know, is this variation that's actually unwarranted, or is it warranted within our population? And that's the starting point that we've looked at with our clinicians, commissioners and directorate managers in the room. So sorry to the clinicians if I'm teaching you to suck eggs, but in terms of MSK, where we focused is largely on osteoarthritis. So the NICE guidance tells us that what we should be doing is taking a holistic approach with anybody with osteoarthritis. So giving them an opportunity to learn more about their condition, to increase their exercise, to lose weight if that's appropriate, and to do some care planning and shared decision making with them so that they're making choices in terms of conservative management options open to them. We know that arthritis isn't always progressive. So actually, the conservative management options may be all that people need to improve their functionality and reduce their pain, and they may never need to go down the surgical pathway. But for others that do, it prepares them so that they can have better outcomes at the end of their surgery. So with that in mind, this is a busy slide, so apologies. This is what helped us tell a story within the room. So this is our right care data. And you've got each of our 8 CCGs along the bottom here. These little wee diamonds are the prevalence of osteoarthritis for each of the CCGs compared to their 10 demographic peers within their right care group. And you can see that the prevalence of osteoarthritis is pretty much the same compared to demographic peers right the way across all of our 8 CCGs. This is the number of procedures per 100,000. The dark blue is the CCG, the light blue is their demographic peers. So right the way across the piece, we've got slightly higher number of procedures per 100,000 of our patients compared to our demographic peers. But yet when you start to look at outcomes, and this is quality of life, EQ5D, compared to our demographic peers, we're not doing so well in terms of health gain after surgery. So it makes you start to question what's going on here. We've got the same picture. That was total knee replacements. This is total hip replacements. Same picture again, pretty much the same in terms of prevalence of osteoarthritis of the hip, higher numbers of total hip replacements compared to our demographic peers, but quite a difference in some of the CCGs in terms of outcomes. We're not doing so well in terms of improving quality of life for our patients after their surgery. So it's made us start to think about what are we actually offering patients at the front end of our pathway? Are we offering them opportunities to learn about their condition, to self-manage, to have conservative options in terms of their management? How are we going to start to make use of the new things that are coming our way? So first contact practitioners, these are physiotherapists sat within our primary care networks. Are we having good quality shared decision-making conversations with our patients? Do we train clinicians in that? Largely no. But we've got other areas of variation as well. So we had a visit from Tim Briggs, I'm getting it right first time, looking at our variations in terms of surgical outcomes. And certainly at the start of the programme with Getting It Right First Time, there was quite significant variation in terms of infection, in terms of revision rates after that people had had total hip replacements, total knee replacements. There's variation in terms of number of procedures per surgeon per year. So the recommended is that surgeons should be doing 30 or more of a certain procedure. This is total hip replacements per year. And certainly you've got the different coloured trusts within our patch. You've got quite a few surgeons doing over 50 a year, great. But we've got some surgeons that are doing less than 30 procedures a year. This is revision rates within a year of having a total knee replacement. This is the national average, and we've got some surgeons where they've got higher revision rates. We need to understand that. So within the room, we asked these clinicians and commissioners and directorate managers to start to think through and understand what's going on here, what's creating this variation, and then starting to apply their collective wisdom and knowledge in terms of the evidence base, but also lived experience in delivering these pathways to co-create evidence-based whole patient care pathways here, using some of the opportunities that's coming our way, such as the first contact practitioner, but very much focused on improving value, improving outcomes, but also clinician experience. So we got them process mapping. So we grouped them around the sort of acute trust area with the community providers, the acute trust providers, primary care, clinicians, commissioners, managers. And they came out with a whole heap of potential issues and opportunities as we asked them to map out the patient journey. So what's happening at the moment with our patients as they have their osteoarthritis and they're going through the options we've got in terms of service delivery for them. You've heard where the evidence base lies in terms of NICE, where are the gaps and opportunities within that pathway. And they largely centred around looking at the sort of front end, primary care, what are we offering patients in terms of education? There was a real disparity across the patch, some big gaps. What are we offering in terms of self-management, in terms of conservative management? Issues around digital, no surprise to anybody. You know, can we see each other's records? No. Can the patient see their record? There's care planning opportunities there. Some issues around performance in terms of RTT, the waiting times for our patients to get to see a physiotherapist, workforce issues within those pathways as well, particularly with physios, and then issues within the surgical pathway. So list goes on. We had great engagement, but actually we need to focus on one thing. And how do we get to a point within these 50 plus people within the room to focus on the one thing that we're going to do initially together? So I'm going to hand over to Paul.
Grab the clicker. So this is where I come in, because I'm the best possible value lead facilitator. And you've seen a whole host of very, very useful, informative information on Karen's slides. The SDP East Surrey and Sussex covers about 1.7 million population. There are 24 organisations. You've seen a lot of information about unwanted variation, a lot of information, rich information about the MSK pathway and the issues. And the problem with life sometimes is you can't see the woods for the trees. Where do you start? Is there a way of actually working through on a particular issue, start, finish and implement, and then get some momentum and then go on to another issue, start, finish and implement? And quite often in the health service we're very good at picking on the complexity, on the wicked issues to do nothing. So what best possible value is, it's a set of tools to help us make decisions. And it's very important, particularly in the new world of system working, whether it's the primary healthcare network or whether it's an SDP or an ICS, we're moving beyond individual organisational boundaries. I've been a Director of Finance for 16 years, and it's relatively difficult, but still achievable, to get a decision implemented and owned through an organisation where there's a chief executive, where there's a board, and get that implemented. But in a world of system working, the East Surrey and Sussex SDP, 24 organisations, the way you get things owned, the way you get people engaged, is perhaps more important than the thing you actually agree on. What you agree on is most probably be fit for purpose, it'd be good, but if you don't pay attention to the way it's developed and owned, you've got no chance at all about it being implemented. So best possible value is a set of 12 tools that helps organisations and systems own an issue. And I won't go through the tools in great detail, but on the right-hand side, a key document is a decision charter, getting people to actually decide what is the decision we want to make. And we'll go on in a few minutes and Karen will describe, out of all that rich information on MSK, what was the key issue that 50 people in a workshop covering all the key stakeholders, what was the issue that they wanted to focus on? And that was really important, because after that was made, that decision was made, and we signed it off at the second workshop, there's no going back. They all agreed that that was the issue they wanted to focus on. There's some internal ones around decision steps, but the third template in the toolkit, or the third tool, the value measures. And the value measures get a whole group of people in this instance we had 50 people at the workshop, to say, well, we've agreed to focus on an issue, but when we look at the options and when we choose our preferred option, we're going to do that against a set of criteria. And we agree those criteria in advance. So what does good look like? And if we agree what good looks like, how do we measure good? That's really important, that value is based on outcome over resources. So for MSK, what's a good outcome? Can we all agree? For MSK, we agree that's a good outcome, a good set of criteria. How do we measure that? We'll all agree. Money is quite useful and interesting because we can all agree a pound is a pound and it's easy to quantify. But in terms of outcome, whether that's experience or safety or quality, it's much more open to debate. So again, the Best Possible Value Toolkit can help you go through and have those conversations in a collective, co-created way, which is really powerful. As you go through the actual tools in a systematic way, you come right towards the end, which is the options. By now, you'll have created 5 or 6 different options. You'll be comparing them against the values and the criteria, and you'll end up, hopefully, with the preferred option. But I'll stress this again, it's very much about the option is the option, but everybody would have been on that journey. So in the example of what we're working on at the moment in East Surrey and Sussex STP, 50 people, all the key stakeholders, all the organisations affected by this decision will have been on that journey, which makes it much more likely that people will implement. So in summary at this stage, the 12 tools can get sort of bundled into 3 phases. There's the first phase on decision planning, very much about what decision you want to focus on, how you're going to frame that decision, who's going to be involved in decision making. That's where, if you heard this morning the presentation from the Royal Free, that's where the RAPID tool comes in, part of decision planning. Who's making the decision? Which board? Is it a trust? Is it the CCG? Or is it the STP commissioning board? There's a set of there's a phase and a set of slides and tools around value generation. And then finally, there's a set of tools around actually, you've done all the hard work. So a bit like the Eurovision Song Competition, how are you going to end up scoring? Which option's going to win? So that's a very quick overview of the Best Possible Value set of tools. With 12 tools broken into 3 phases. But the key thing I'll say is, it helps you take all that rich, detailed information that Karen started with, and it puts it through a structured process of 4 workshops that people can actually get some ownership and understanding. And then hopefully you can make a decision at the end of the 4th workshop. So this is where we've got to. We've actually had our 2nd workshop, so we're setting up for our 3rd workshop on the 9th of July.
Absolutely. Thank you. Thanks, Paul. So out of all of those opportunities and gaps that we that came out of our process mapping that we did, within 4 sort of subgroups around our play spaces, we asked those clinicians and commissioners and managers to start to think through and populate this template. So looking at the situation, interestingly, after a great deal of discussion on the table, they all came to the same conclusion. So what they wanted to deal with was the variation in patient pathway right at that front end there. What are patients being offered in terms of education, in terms of self-management opportunities and conservative management? They wanted to deal with some of the variation in terms of referrals from GPs, but also that patient knowledge base. They were particularly interested in how we use digital platforms to support patients with that, but also clinicians. They wanted to improve the shared decision-making conversation with patients. And they recognise within complications that the situation we're in currently is financially unsustainable. They wanted to address some of the issues around RTT, around some of the local use of AQP providers, but also some of the quality aspects within variation in imaging, in length of stay within that. So this is the decision we collectively as a room came together with. So to focus on that initial pathway in MSK, to empower people to self-manage and have that opportunity to access conservative management approaches and, where appropriate, onward care into musculoskeletal services, as well as post-operative rehabilitation. So the next thing we asked them to do was actually look right at the other end of the pathway. Where are we trying to get to? What is it that we want to achieve and see in place for our patients? What does good look like? So actually working through this template was really valuable in trying to just rein in some of the thinking into particular themes. So looking at patient outcomes, people want to focus on reducing pain, improving functionality, improving quality of life, ensuring people get back to work again. Looking at user experience in terms of accessibility of a service, and the metrics that go alongside that. So MSK-HQ is a good generic outcome metric, looking at things like PAM, the patient activation measure, to measure knowledge, skills and confidence, to self-manage, collaborates and measurement of shared decision making. So all these things that were important to those clinicians and managers and commissioners in the room are played out in terms of these value metrics that they've chosen. So looking at safety and quality and cost. We've then done some work in this workshop we've literally just had last week, so it's actually more than this. So we've captured some of it here in terms of, okay, what do those options look like? So what can we use in terms of the delivery vehicles, if you like, for this? So there's options around, do patients self-refer? Does it happen via a clinician? What level of physiotherapist are you working with to deliver that front end of the pathway as a first contact practitioner in primary care? What does the governance look like? Is that sort of hub-based, more centralised? Is it down in the primary care network in terms of clinical governance and organisational governance? Where's the service actually based? So lots of things to work through that we're now taking away as a project team to work up into a high-level options appraisal. And the next step in the next workshop will be to map out those value metrics and score against those high-level options appraisal to find that preferred option for us to then work up as a project team and take through our governance process. So I'll hand back over to Paul. Thank you.
So we're halfway through a series of 4 workshops, and I can't stress enough, Caroline Clark, when she was here this morning, talked about in the Royal Free, they originally set up as a Vanguard site and worked on a whole range of care pathways. And they thought, job done, we've got a range of care pathways. And they met resistance when they were trying to implement those care pathways. So her words were, we had to go back and be humble and sort of say we're going to rework these care pathways in partnership. And the phrase she used, she wanted the system or GPs or organisations and key clinicians to pull the pathways from them. So to pull the things, so they're actually not the Royal Frees pushing the Royal Free sort of solution of the world, but actually people pulling the answer to their problem. So the process we've gone through about getting everybody to agree, 50 individuals, this is the key decision we want to look at. We don't want to look at expensive hip, knees and joints and length of stay in the acute hospital. We want to look at the front part of the pathway. Also getting 50 people to agree on this is what good looks like and this is how we'd measure good against their ownership. So the next stage would be, if this is a perfect world, if this conference was in about 3 months' time, we'd have one of these slides completed for MSK in East Surrey and Sussex. But actually, we have 2 more workshops to go. So at the end of the process, this is what one of the key templates will look like, and this will be completed for MSK, but this is an example for maternity. And you can see the value criteria for outcomes and the resources. You'll see that the group will have weighted those criteria, because not all criteria are of equal value. And you'll see that there'll be sort of definitions of basically score 1 to 5, or you could do 1 to 4 or whatever. You'll also see that the groups will have identified there's another dimension of risk, which I'll come on to, and a further third dimension of strategy will be introduced as well. Because take an example of maternity, you might say the best solution for maternity hospital might be to have maternity services centralised on hospital site X. The only problem being the risk could be to implement that would be very, very risky because it might take an awful long time. The world can't wait that long. Or in terms of strategy, what if the SDP had decided elsewhere to close Hospital X? It might be the best answer for maternity, but it's not the best answer for the system because they're going to close Hospital X. So there are three dimensions to any decision. The best value for that particular decision, the risks around implementing that decision, and does that best possible value for that decision link in with a system-wide strategy? So you'd end up scoring, and the scoring will be done collectively. That's the aim and the objective in East Surrey and Sussex. So using the criteria that we'd agreed earlier, we will aim to get some scoring done against the various options. And then there's a further tool to actually graphically present the scoring. Same information, but shown slightly differently. And in this instance, you would see that option 2 gives the highest value. Option 2 gives the lowest risk, and because it's colour-coded green, it also gives a high alignment to the strategic factors. So if I was sat on an STP board, I'd say, do you know, it's a bit of a no-brainer. Option 2 looks like it's the preferred or the best option on all three of those areas. And therefore we have a decision, but not just a decision that a handful of people would have owned, but a decision that 50 people would have owned, and also their organisations who are supporting them attending these workshops should also own as well, hopefully. And I can't stress enough that working in the health service for over 35 years, it's very difficult to implement things in a command and control way. So the major tool we have is influence, and if we can engage people in the process, then by engaging them, hopefully they will own it, and therefore they will hopefully implement it. So that's really our sort of journey in East Surrey and Sussex. It's very important to me that it's clinically owned, and I think with Karen and the team it is clinically owned, and I think there's a very good chance of what comes out of it will also be implemented.